ಡಾಕ್ಟರ್ ವಿ ಡಿ ಸಫಾರೆ ಅವರು ತೀರ್ಕೊಂಡಿದ್ದಾರೆ, ನಮ್ಮ ಹಿರಿಯ ಸದಸ್ಯರು. ಈಗ ಜಸ್ಟ್ ಇನ್ಫಾರ್ಮೇಶನ್ ಬಂದಿದೆ ಸರ್. ಸೊ ಅವ್ರಿಗೊಂದು ಮಾರ್ನಿಂಗ್ ಪ್ರೇಯರ್, ಸೈಲೆನ್ಸ್ ಪ್ರೇಯರ್ 1 minute ಸರ್.
ಆಯ್ತು.
ಬ್ರೇಕ್ ಸರ್.
ಥ್ಯಾಂಕ್ ಯು.
ಸೊ ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. So today the topic is by Dr. Suri Raju, common neurological problems in general practice, and I start with IMA prayer. May everybody be happy, may everybody be healthy, may everybody be free from pain, may everybody be free from sorrow, may we be the healing cure beyond every greed and endure. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you. Over to Dr. Karavira Prabhu, Calcunda sir.
ಎಲ್ಲರಿಗೂ ಸಂಜೆಯ ಶುಭಾಶಯಗಳು. ಇಂದಿನ ವೆಬಿನಾರ್ ಕಾರ್ಯಕ್ರಮದ ವಿಷಯ ಕಾಮನ್ ಯೂರಾಲಜಿಕಲ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇನ್ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಸ್. ತಮಗೆಲ್ಲ ಇಷ್ಟವಾಗಬಹುದೆಂದು ಭಾವಿಸುವೆ. ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಆತ್ಮೀಯರು, ಕರ್ನಾಟಕ ರಾಜ್ಯ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ರಾಜ್ಯಾಧ್ಯಕ್ಷರೂ ಆದ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯನವರಿಗೆ ವೈಯಕ್ತಿಕವಾಗಿ ಮತ್ತು IMA KSB CGP ಕರ್ನಾಟಕ ವತಿಯಿಂದ ಹೃತ್ಪೂರ್ವಕವಾದಂತಹ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ. ಆತ್ಮೀಯರು, ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಗೌರವ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಸೂರಿರಾಜು ಇವತ್ತಿನ ಉಪನ್ಯಾಸಕರು, ಹಿರಿಯ ಯೂರಾಲಜಿಸ್ಟರು, ಎಂಡ್ರಾಲಜಿಸ್ಟ್ ಮತ್ತು ಲೆಪ್ರೋಸ್ಕೋಪಿಕ್ ಸರ್ಜನ್, MD ಮತ್ತು CEO ರೀಗಲ್ ಹಾಸ್ಪಿಟಲ್ ಬೆಂಗಳೂರು ಅವರಿಗೆ ಹೃತ್ಪೂರ್ವಕವಾದಂತಹ ಸ್ವಾಗತ. ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಹರೀಶ್ ದೆಲಂಬೆಟ್ಟು, ನಿಕಟಪೂರ್ವ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ VV ಚಿನಿವಾಲರ್, IMA KSB CGP ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಮಹೇಶ್, ಹಿಂದಿನ ಎಲ್ಲ ರಾಜ್ಯಾಧ್ಯಕ್ಷರುಗಳಿಗೆ, ವೆಬಿನಾರ್ದಲ್ಲಿ ಪಾಲ್ಗೊಂಡ ತಮಗೆಲ್ಲ ಹೃತ್ಪೂರ್ವಕವಾದ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವರಿಗೆ ಇಂದಿನ ಉಪನ್ಯಾಸಕರಾದ ಡಾಕ್ಟರ್ ಸೂರಿರಾಜು ಅವರ ಪರಿಚಯ ಮಾಡಿಕೊಡಲು ಕೋರಿಕೆ.
Dr. Suriraju V, MBBS MS DNB Urology, MD and CEO Regal Hospital. He is also Honorary Secretary IMA Karnataka State Branch 2024 to 2026. He is an experienced urologist and a healthcare leader with 22 years of experience, and he has conducted around 12,000 plus renal surgeries, leading a hospital of 100-bed kidney and multi-speciality hospital in Bangalore with focus on advanced and affordable kidney care. Key achievements: National IMA Best Secretary Award in 2025. Best Doctor Award Vijay Karnataka 2024 for community service, and a Gold Book Award winner, and is also a winner of Amazon bestseller author Kidney Secrets Revealed, and is also a award winner of Kidney Wellness Handbook author in 2026. Committed to the strengthening IMA, promoting kidney disease prevention and expanding accessible healthcare services. So by this, I welcome a warm welcome to Dr. Suriraj sir. Sir, please continue, sir. And I also welcome Dr. Karavira Babu Kalkonda, Dean and Director of IMA CGP Karnataka State for this webinar, sir.
Thank you.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಮೊದಲನೇದಾಗಿ ನನಗೆ ಇವತ್ತಿನ ವೆಬಿನಾರ್ಗೆ ಮಾತನಾಡಲು ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿರುವಂತಹ IMA CGPಯ ಡೈರೆಕ್ಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕರವೀರ ಪ್ರಭು ಕ್ಯಾಲಕೊಂಡ ಅವರಿಗೆ ನನ್ನ ವಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರು ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ ಅವರಿಗೆ ನನ್ನ ವಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ಮತ್ತು ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಜಿ ಸೆಕ್ರೆಟರಿ IMA KSP CGP ಅವರಿಗೂ ಕೂಡ ನಾನು ವಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ನನಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿದ್ದಕ್ಕೋಸ್ಕರ ತಮಗೆಲ್ಲರಿಗೂ ಧನ್ಯವಾದಗಳು. ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದಿರುವಂತಹ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರುಗಳು, ಮಾಜಿ ಅಧ್ಯಕ್ಷರುಗಳು ಮತ್ತು ಎಲ್ಲ ಆ್ಯಕ್ಟಿವ್ ಮೆಂಬರ್ಸ್ ಕೂಡ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಾನು ಸುಸ್ವಾಗತವನ್ನು ಕೋರುತ್ತಾ, ನನಗೆ ಐ ವಾಂಟ್ ಟು ಥ್ಯಾಂಕ್ Dr. Mahesh for a wonderful introduction. Whether I deserve that much or not, he has given very good introduction. So, ತಮಗೆ ಗೊತ್ತಿರುವ ಹಾಗೆ ಲಕ್ಷ್ಯ give me some 1 minute time. I want to share the slides. John, can you see the screen?
No, sir. There only it is, sir.
Right.
On your just besides that bin. Yeah. Yes, sir. Now we can see it, sir. You can make it full screen and start, sir. Yes, it's visible, sir. Yes, sir. Yes, sir.
Thank
Your
you.
video is off, sir.
Video is not.
Zoom video. Now it's on, sir. Perfect, sir. Perfect.
Yeah. Today, I'm going to speak on common neurological problems seen in general practice by the general practitioners. And as you are aware, in general practice, the cases attended by general physicians, urologists, surgeons, gynecologists, orthopedic surgeons, even neurologists. I will tell why neurologist I am telling this. 20 to 30% of the cases they come across with urological complaints. It is so common. why this topic is important? Because if you diagnose early, if you diagnose and refer the patient to the urologist on time, we can prevent renal failure, urosepsis, and cancer progression. Most of the symptoms are due to 3 reasons. In urology, nothing more. It is very simple subject. Most of the symptoms are due to obstruction. Why obstruction? Ureteric obstruction, then PUJ obstruction, then prostatic obstruction, like that. Most of the symptoms are due to that. Second thing is infection. Upper urinary tract infection, lower urinary tract infection, infection due to diabetes mellitus, infection due to stone obstructing the kidney leading to urinary tract infection, like that. Third reason is cancer and cancer progression. Kidney tumors, ureteric tumors, bladder tumor, prostate carcinoma. So how the patients, most of the time they present? They will present with abdominal and flank pain, loin to groin, sometimes right iliac fossa pain, radiating to the testes also. Second most common symptom is lower urinary tract symptoms. Either patient may have dysuria, increased frequency, then burning urination with pus in the urine, or poor stream of the urine. Blood in the urine. Some patient will have blood may be associated with dysuria, sometimes frank hematuria, painless hematuria. Another important symptom is poor urinary stream. Illari nange yako ಒಂದು ವಾರದಿಂದ ಸರಿಯಾಗಿ ಯೂರಿನ್ ಆಗ್ತಾ ಇಲ್ಲ. ಪೂರ್ ಸ್ಟ್ರೀಮ್, ತುಂಬಾ ತಿಳ್ಕಾಡಬೇಕಾಗುತ್ತೆ ಒಂದ ಮಾಡೋದಕ್ಕೆ. ರಾತ್ರಿ 7-8 ಸರಿ ಎದ್ದೇಳಬೇಕಾಗುತ್ತೆ. ಒಂದ್ಸರಿ ಹೋಗಿ ಬಾತ್ರೂಮ್ಗೆ ಹೋಗಿ ಒಂದ ಮಾಡಿದ್ರೂ ಸಹ ಸರಿ ಹೋಗಲ್ಲ ಅಂತ ಸ್ಯಾಟಿಸ್ಫ್ಯಾಕ್ಷನ್ ಇಲ್ಲ. This is the way they present. As I told earlier, 30% in general practice I was telling. Before starting this, on a lighter note, one of my neurology friend called me. ಏನಪ್ಪ ದಿನಕ್ಕೆ 2ರಿಂದ 3 ಕೇಸಸ್ ಯೂರಾಲಜಿ ಕೇಸಸ್ ನನಗೆ ಬರ್ತವೆ ಅಂತ. ಐ ವಾಸ್ ಶಾಕ್ಡ್. ಯಾಕಪ್ಪ ನಿನಗೆ ಯಾಕೆ ನ್ಯೂರಾಲಜಿ ಕೇಸಸ್, ಸರ್ ಯೂರಾಲಜಿ ಕೇಸಸ್ ಬರುತ್ತೆ? ನನ್ನ ರಿಸೆಪ್ಷನಿಸ್ಟ್ಗೆ ಫೋನ್ ಮಾಡ್ತಾರೆ, ಯೂರಾಲಜಿಸ್ಟ್ ಇದ್ದಾರಾ ಅಂತ ಕೇಳಿದ ತಕ್ಷಣ ಅವರು ನ್ಯೂರಾಲಜಿಸ್ಟ್ ಅಪಾಯಿಂಟ್ಮೆಂಟ್ ಕೊಟ್ಬಿಟ್ಟಿರ್ತಾರೆ. ಅದ್ರ ದೊಡ್ಡ ಸಮಸ್ಯೆ ಆಗ್ಬಿಟ್ಟಿದೆ ನನಗೆ. ಅದೇ ಥರ ನನಗೂ ಕೂಡ ನ್ಯೂರಾಲಜಿ ಕೇಸಸ್ ಭಾಳ ಬರ್ತವೆ. ದಿನಕ್ಕೆ ಅಟ್ಲೀಸ್ಟ್ ಒಂದು ವಾರಕ್ಕೆ ಒಂದ್ಸರಿ ಅಥವಾ 2 ಕೇಸಸ್ಸು. ಬಿಕಾಸ್ ಪೀಪಲ್ ವಿಲ್ ಗೆಟ್ ಕನ್ಫ್ಯೂಸ್ಡ್. ಅಥವಾ ಅವ್ರು ಹೇಳ್ಬೇಕಾದ್ರೆ ಸರಿಯಾಗಿ ಕೇಳಿಸ್ಕೊಂಡ್ರೆ ಗೊತ್ತಿಲ್ಲ, ನಮ್ಮ ರಿಸೆಪ್ಷನಿಸ್ಟು ನ್ಯೂರಾಲಜಿ ಕೇಸಸ್ಗೆ ಯೂರಾಲಜಿ ಕೊಟ್ಟಿರ್ತಾರೆ, ಯೂರಾಲಜಿ ಕೇಸಸ್ಗೆ ನ್ಯೂರಾಲಜಿ ಕೊಟ್ಟಿರ್ತಾರೆ. ಹಾಗಾಗಿ ವಿ ಕ್ರಾಸ್ ರೆಫರೆನ್ಸಸ್ ವೆರಿ ಕಾಮನ್. So it is very important to know the anatomy of kidney, ureter, and bladder and prostate. Based on this, treatment is decided. As you all are aware, kidney has got multiple functions. It excretes waste materials from the body. It plays a key role in water balance, acid base balance. It also secretes a hormone called as erythropoietin, which is required for the synthesis of the RBC. And also, it has got, it controls the blood pressure. Ureter, the bladder, as well as the prostate and urethra, they act as the part of the excretory system. So most common complaints patient we come across is renal and ureteric stones. There is a saying, ಆಡು ಮುಟ್ಟದ ಸೊಪ್ಪಿಲ್ಲ. ಅದೇ ತರ ಕಿಡ್ನಿ ಸ್ಟೋನ್ ಟಚ್ ಮಾಡಿದಂತಹ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರು ಇಲ್ಲ, ಕಾಮನ್ ಪೀಪಲ್ಲು ಇಲ್ಲ. ಯಾಕಂದ್ರೆ ಇದಕ್ಕೆ ಎಲ್ಲರೂ ನೋಡಿರ್ತಾರೆ, ಎಲ್ಲರೂ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿರ್ತಾರೆ. ಸೊ based on the size of the stone, site of the stone, location of the stone, and content of the stone, different varieties are there. In simple classification for everyone's understanding, kidney stone, upper ureteric stone, lower ureteric stone, bladder stone, and mid ureteric stone. Why this is very, very important? Because the management is based upon the site of the stone size of the stone, and associated infection. These things are important. Suppose you come across a patient with severe colicky pain associated with nausea and vomiting fever. It is definitely a danger sign, because once the patient develops fever means ureter, the stones is obstructing the system. There are chances that patient may go for urosepsis. Some patients may present with only hematuria. It is on the way. Sometimes these ureteric stones irritate the mucosa of the ureter or the bladder wall and causes sometimes significant hematuria. As I told earlier, there are different kinds of the stones. Calcium oxalate stones are very common. Struvate stones around 10 to 15%. Uric acid stones, it's more common in diabetic patients. Cystine stones, recurrent urinary tract infections, people come across cystine stone. Struvate stones are very common in diabetics, especially long-standing recurrent urinary tract infections. So it is important to know the kind of stones, because treatment is based again the type of the stones. There are multiple options are available in front of us. Medical treatment, when you should give the treatment medical. In general practice, it is important when we can treat the patient, when we should refer the patient to the higher center or super specialist. This is very important. If the stone size is less than 4 millimeter, if the stone is in the kidney or mild hydronephrosis is there, medical line of treatment is advised. Okay, then if the stone size is around 6 millimeter or above 6 millimeter, ureteroscopy is advised. If the stone size varies between 4 to 6 millimeter, wait and watch policy can be employed depending upon the symptom and associated symptoms for 2 to 3 weeks. Again, nowadays, flexible ureteroscopy, PCNL, ESWL. Why I am stressing on ESWL is because the moment general practitioner come across renal stones, 2-3 mistakes they do. One is, they will not assess the size of the stone. They will not think about associated comorbidities and other conditions. Before proper evaluation, some general practitioners refer the patient straight away for ESWL. What happens at ESWL? Most of the time, the stone is fragmented by technicians. We are the clinicians. We should assess the patient whether he is the right candidate for ESWL or not. That is very important. ESWL is ideal if the stone size is less than 1 to 1.25 centimeter only. And before sending the patient for ESWL, make sure that there is no associated urinary tract infection. Third thing is, always cross-check the creatinine is normal limits or not, and patient is pregnant or not, any coagulation abnormality is there or not. These prerequisites are very important before sending the patient for ESWL. Why? Because when we do lithotripsy, most of the people assume that it is a OPD procedure, simple procedure, daycare procedure, need not worry, like that. Sometimes patient may go for sepsis. Sometimes patient may go for acute renal failure. Sometimes they will have severe bleeding. And sometimes when ESWL is done for pregnant women, it may cause abortion. Another important thing is, sometimes I come across so many patients, again after 3 or 4 sittings, number of sittings of ESWL is also important. We can't just keep on fragmenting the stone. Let the 5 sittings, it is not advised. Minimum or maximum 3 sittings or 4 sittings, not more than that. What happens if you give too many sittings? It will cause nephron injury there are chances of losing the kidney. So before sending the patient for ESWL, take proper steps, because ESWL is right now available and accessible to everyone at every place. So it is ideal if the stone size is 1 centimeter, less than 1 centimeter. And again, we have to assess whether it is radiolucent stone or radio-opaque stone. As I told earlier, proper assessment. We are clinicians. We should not, even though advanced technology is there, CT scan is there, we should not forget proper history taking. We should not forget keeping our hand on the patient, because many things can be diagnosed just by clinical examination. I'm just telling one example. Patient with acute retention of urine, patient underwent extensive investigations, then physician or doctor realized that it is acute retention of urine. If he would have just kept his hand on the suprapubic region, he would have diagnosed it. So in our routine practice, and if you are in our busy practice, sometimes we fail to do basic steps. We should not do that. Another important aspect which I want to highlight is about the flush therapy for renal stones. It is very routine practice everywhere. Kidney stone means admission and flush therapy. I want to clarify one important thing. There is no role of flush therapy. It is abandoned long back. There is no role of, why I'm telling, because suppose let us assume upper ureteric stone. What happens if we give IV fluids? The fluids are excreted by not that kidney, opposite kidney. You will produce a lot of urine. We assume that, okay, there are chances that the stone may push, the fluids will push the stone out. It will not happen. What happens when kidney obstructed stone causes temporary paralysis of the kidney? It will not function for time being. It will not excrete. It will produce the urine, but not able to, urine is not excreting, mild hydronephrosis will happen. Opposite kidney will take over the function. So how much ever fluids you give, it is useless. It is very important to know no role of flush therapy. Again, too many misuse of painkillers should not be given. Suppose patient is not responding to simple painkillers, immediately refer or call urologist. Some intervention may be required. Again, in this renal stones, blindly starting antibiotics should not be encouraged. The flexible ureteroscopy, nowadays it has become very popular. Up to 2 centimeter renal stones can be managed without any cut. Endoscopic procedure, extension of the ureteroscopy, that's all. We are going into the kidney and fragmenting the stone using the laser, and even we are doing these days fans also. What is fans? Flexible and navigable suction. After fragmentation of the stone, we are sucking all the stones. So I would like to show a small video. It is very, what we are doing here. Renal stones. This is flexible ureteroscopy, approximately 65 centimeters. Fans. This is flexible and navigable suction, ureteric access sheath. Using suction apparatus, you can remove the stones from the kidney. This is the latest advanced treatment for renal stones. The big advantage is the daycare procedure, patient can go home. Again, basics we should not forget. Always culture sensitivity, antibiotic under antibiotic coverage will be. beauty of this suction apparatus is the residual fragments by doing suction, we can remove entire suction. So, sorry. Just 1 minute.
Yeah, no problem, sir. Yes, visible, sir. Visible, sir. Yes.
So this is the modern advanced treatment for renal stones. Again, next slide, please. Laksha. I'm taking my help from my daughter. She's expert in this. Yeah, next slide. Yeah. Again, another important procedure you might have heard about, percutaneous nephrolithotomy. Still, it is the gold standard surgery for renal stones, especially if the stone is more than 2.5 centimeter. Staghorn stones. That means if the stone is extending, 2 or 3 calyxes, it is still ideal. There is always limitation when we should do ESWL, when we should go for flexible ureteroscopy, and when we should go for PCNL. So PCNL this one is, I'm showing one Staghorn stone we operated. I know the beauty of this treatment is take care procedure nowadays. See, this is Staghorn stone. And most of the time, the best landmark for entering into the lower calyx is the tip of the 11th rib. Here is the case of 5 centimeter right-sided renal calculi, which is Staghorn calculi. We have done supine PCNL. Stone clearance was done in the single.
Sir, you have to shift it to minimize the slide, sir.
All calyx.
Just minimize this slide.
You are not able to see?
No, sir. It's in the background. Just minimize this slide.
Aksha. You're not able to see? What is it?
No, sir. It is in the background. It is playing, but this slide has to be minimized so that we can see the.
Okay, sorry.
Yeah. No.
So, now it's clear?
No, sir. No.
No, sir.
Okay. You're able to see now?
No, sir. No. You can just stop sharing, sir. Once.
Okay, you can do that.
ಸರ್ ಜಾನ್ಗೆ ಕಳಿಸ್ಬಿಡಿ ಅವನು
ಆಯ್ತು
ಮಾಡ್ತಾನೆ.
John, you can do that.
Yeah. This one only, sir. Yes. Please, sir.
Can you see now?
Yes, sir.
So the best landmark for entering into the lower calyx is the tip of the 11th rib. Here is a case of 5 centimeter right-sided renal calculi, which is Staghorn calculi. We have done supine PCNL. Stone clearance was done in the single puncture through the lower calyx, able to reach all calyx through the lower calyx. So supine PCNL without. Next slide.
You have to share the slide, sir. Now it's coming, sir. Yes,
So
sir.
again, now a lot of advances are happening in PCNL. Percutaneous nephrolithotomy, before they used to do in prone position. Now we have shifted to supine position. Most of the cases we are doing in supine position. The big advantage is, one of the disadvantages prone position is, due to positional changes, there are some injuries are noted. But in supine PCNL, it is very convenient for anesthesiologist also. So supine PCNL is ideal, especially mid and lower calyceal stones. Again, one more most common problem which we encounter in our routine practice by the general practitioners and general practice is benign prostatic hyperplasia. The symptoms, there are two kinds of symptoms: irritative symptoms and obstructive symptoms. Poor stream of the urine, urgency, increased frequency, sensation of incomplete emptying of the bladder, nocturia 5 to 6 times during night hours, and ಒಂದ ಹೋಗ್ಬೇಕಂತ ಮಾಡ್ತೀನಿ ಒಳಗಡೆ, ಬಟ್ ಸೆನ್ಸೇಷನ್ ಬರಲ್ಲ, ಯೂರಿನ್ ಮಾಡ್ಬೇಕಂತ ಅನ್ಸೋದೇ ಇಲ್ಲ, ಇನ್ಕಂಪ್ಲೀಟ್ ಆಗುತ್ತೆ, ಮುಕ್ಕಬೇಕಾಗುತ್ತೆ ಒಂದ ಮಾಡಬೇಕು ಅಂತ. ಸೊ ದೀಸ್ ಸಿಂಪ್ಟಮ್ಸ್ ಆರ್ ಕಾಮನ್. Again, one important thing I would like to highlight here is, whenever people think about benign prostatic hyperplasia, they straight away start medications. No, there are indications when the medications should be started. Suppose there is a score called as International Prostate Symptom Score. If the score is less than 7, we can observe the patient. If IPPS is between 7 to 19, medical line of treatment is advised. If the patient is, the symptoms are more, not responding to the medication, and patient don't want to continue the medication, then there is role of prostate surgery. Now, open surgery is slowly converted to transurethral TURP, then followed by laser surgery. Now, latest advanced treatment for prostate is resume water vapor therapy. So I would like to tell what is resume water vapor therapy. So one important thing I would like to highlight is, not all enlarged prostate need surgery. Suppose I'm asymptomatic, I don't have any complaint. Incidentally, my prostate is enlarged. I don't require medications nor surgery. Again, not all BPH requires medications. Always important to rule out cancer prostate. CA prostate can be diagnosed by doing simple tests. For rectal examination, see for any hard nodule or not. Another thing is, check for the serum PSA. Serum PSA is elevated in cancer prostates. Again, it is not cancer specific, it is prostate specific. Serum PSA may be elevated in urinary tract infection also. So it is important to wait and watch for 3 to 4 weeks. After 4 to 6 weeks, again repeat serum PSA. If you are highly suspicion of any cancer prostate, then you can do transrectal ultrasound or MRI of the prostate, then treat the underlying cause. Again, role of the treatments like alpha blockers. Most common advised medication is tamsulosin, silodosin, and alfuzosin. We should know what are the symptoms and complications of these medicines also. Orthostatic hypotensions are very common with these medications. So always explain the patient, when you start taking this medicine, 2 ದಿನ ನೀವು ಗಾಡಿ ಮೇಲೆ ಅಡ್ಡಾಡಬೇಡಿ, ಗಾಡಿ ಓಡಿಸ್ಬೇಡಿ, ಮನೆಯಲ್ಲಿ ರೆಸ್ಟ್ ತಗೊಳ್ಳಿ, BP ಚೆಕ್ ಮಾಡ್ಕೊಳ್ಳಿ ಅನ್ನುವಂತಹ ಒಂದು ಮೆಸೇಜ್ನ ಕೊಡಲೇಬೇಕಾಗುತ್ತೆ. ಯಾಕೆಂದ್ರೆ ಜಸ್ಟ್ ಇಮ್ಯಾಜಿನ್, ಯು ಹ್ಯಾವ್ ಸ್ಟಾರ್ಟೆಡ್ ಆಲ್ಫುಜಿಸಿನ್, patient falls on the road with hypotension. Okay, it is not correct, right? So always 48 hours, if patient doesn't have any symptoms, after 48 hours, very unlikely that patient will have symptoms. So first 48 hours, we should always tell the patient, observe. If any symptoms, please report. I may stop the medicines or I will give you advice. Another important thing before starting the medication, lifestyle modification, friends. Suppose a patient who is taking 4 liters of water, he will have increased frequency of urine. That time I will tell, reduce intake of water. Suppose I am taking 5 to 6 times coffee or tea, I advise the patient, reduce intake of coffee and tea. I'm a smoker, I'm taking 4 or 5 cigarettes per day. I advise the patient, please reduce and stop. because this coffee, tea, as well as smoking can irritate the bladder mucosa, leading to exaggeration of the symptoms. So lifestyle modification plays a key role before starting the treatment. Again, once upon a time, prostate surgery there are many senior doctors here. Prostate surgery means it was very big. Patient is to sometimes had torrential bleeding and on-table deaths are noted. Post-operative bleeding deaths are noted. Then slowly it replaced with simple surgery called as transurethral dissection of the prostate. Then over a period of time, laser prostatectomy has become popular. Now, TRP means slowly the prostate surgery is getting replaced with resume water vapor therapy. It is a daycare procedure. Just imagine patient coming in the morning, undergoing the procedure, but after 1 hour going home without any problem. That is the beauty of this treatment. I would like to show the video. Please see, this is important. Can you see the video?
I'm Dr. Surya Raju.
Yes, sir. Yes, sir.
Hospital. Water vapor therapy is minimally invasive procedure for benign prostatic hyperplasia. In water vapor therapy, water vapor at 103 degrees centigrade is injected into the prostate gland using the delivery device. At multiple sites, number of injections is dependent upon the size of the prostate gland. Once the water vapor is injected, how does it work? It causes avascular necrosis of the gland. It causes the shrinkage of the gland. Water vapor therapy is suitable for patients with benign prostatic hyperplasia aged 50 years to 60 years who are sexually active. Water vapor therapy is ideal for elderly male who are not fit for anesthesia, elderly males who are scared about anesthesia, males who are with cardiac issues who are not fit for anesthesia. What are the advantages of water vapor therapy? It is a daycare procedure. It can be done under local anesthesia and patient complications are very, very, very less. Water vapor therapy is minimally invasive procedure. It is ideal for the prostate size less than 100 grams. It is just 10 minutes procedure. Patient can go home on the same day. It is ideal for sexually active males because it prevents retrograde ejaculation. It is suitable for patients with cardiac issues who are not fit for anesthesia. Soon after resume therapy,
Next slide. Yeah, this is water vapor therapy. I'm happy to share we have done around 50 surgeries, most probably highest in Karnataka. And we are the first to bring water vapor therapy to Karnataka. When we started this procedure, when there was Medicon at IMA Yelahanka, by IMA Yelahanka, during that time we inaugurated. Again, another important thing is hematuria. Hematuria, it is very important to know whether it is painful hematuria or painless hematuria, whether it is urinary tract associated, urinary tract infection associated hematuria, renal stone induced hematuria, or malignancy induced hematuria. Why this is, I'm stressing on this because some people, symptomatic relief they give, patient, if the patient is having hematuria, frank hematuria, then only patient will follow up with the doctor. The moment patient is free from the bleeding, then they will not come to the doctor. It is very important to recognize hematuria.
especially painless hematuria, and immediately refer to the higher center. Sometimes, because of if you miss symptoms, if you fail to properly take the history, we may miss cancer. So patient may come to the urologist or higher center with advanced stage. So evaluate all hematuria, don't neglect it. Send for urine routine and culture, refer persistent hematuria. Okay, assume all hematuria, please don't do that. Don't consider hematuria as an infection and treat the infection. If you ignore painless hematuria, you are doing harm to the patient. There are various reasons why hematuria occurs: renal tumors, bladder tumors, cancer, prostate. And it is important to diagnose, because one of the beauty in urology is most of the cancers, if they are detected early, they are completely curable. If cancer prostate is detected early, it has got excellent prognosis. If cancer kidney is detected early, it has got excellent prognosis. CA bladder, it is completely curable. Again, another important commonest symptom which we come across in the general practice is urinary tract infection. It is very important to assess male or female, children or adult, upper urinary tract and lower urinary tract, associated comorbidities are there or not. As you all aware, patient come with symptoms like burning urination, fever, frequency, and flank pain. Again, here it is very important to know what is the underlying cause for urinary tract infection. In our routine practice, especially females, we come across with recurrent UTI. There are multiple reasons why people, especially females, they come across urinary tract infection. The reason is they hold the urine for a long time. ಬೆಳಗ್ಗೆ 8 ಗಂಟೆಗೆ ಕೆಲವು ಸರಿ, ರಾತ್ರಿ 8 ಗಂಟೆ ಒಂದ್ಸರಿ ಮಾಡ್ತಾರೆ. There are various reasons are there, especially school children. They want to avoid toilets. They avoid going to the toilets. Especially people who want to travel long distance, they avoid passing urine, hold the urine. It is not toilet-induced urinary tract infection. Holding the urine for long time is the reason for urinary tract infection. Again, people who are having chronic constipation, especially females, they are known for recurrent UTI. So it is important, please don't just start the antibiotic. Patient is having lower urinary tract symptoms. Don't assume that patient is having UTI and start the antibiotics. So identify what is the reason patient is having UTI, whether patient is having uncontrolled diabetes or diabetes mellitus is there or not, any phimosis is there or not, any ureteric stone is there or not. Identify the underlying cause, that treat that underlying cause. Just starting an IV antibiotic is very dangerous because it masks the symptoms. Underlying cause is not treated. Again, one more important thing which we come across routinely is catheterization. Perurethral catheterization, due to wrong technique, sometimes we come across stricture urethra, rupture urethra, and this happens because of the wrong technique. Why we catheterize preoperatively, intraoperatively, postoperative management, we catheterize the patient. There are some reasons why we catheterize in benign prostatic hyperplasia with acute retention of urine and stricture urethra, not able to pass urine. Sometimes we attempt catheterization. Neurogenic bladder, especially diabetes mellitus patients, we do catheterization. Here, very important do's and don'ts are very important. When you do catheterization, under aseptic precaution is important. Choose the right size of the catheter. Lubricate the patient very well. Don't, suppose if you are attempting the catheterization, catheter is not going, don't force the catheter. It will cause urethral mucosal injury, leading to pre-existing reason for stricture in the future. Again, it may cause multiple traumatic strictures, and rupture urethra is also common. So if you are not able to put catheter, just call urologist. Under cystoscopic guidance, under guidewire guidance, he will catheterize. To summarize, it is important identification. Of course, 20 to 30% of the patients with urological symptoms, come to the general practitioners. Fever with obstruction, don't treat, call urologist. Why? Because it may be sepsis. Acute urinary retention, catheterize the patient and refer for the urologist, and he will treat the underlying cause. It may be due to neurogenic bladder. It may be due to bladder stones. We don't know. Gross hematuria, please don't ignore. Renal failure. I have come in incidents where renal failure, acute retention of urine, or both are confused. Patient not able to pass urine last 24 hours. Some people assume that it is acute renal failure. They start the IV fluids. Sometimes just putting, as I told earlier, put your hand on the suprapubic region. The patient is having retention of the urine. It is not renal failure. It is acute retention of urine. Catheterization will solve the problem. Giving IV fluids for already acute retention of patient is crime. At the same time, if just putting the catheter without treating the patient with the renal failure with IV fluids and proper medications is again wrong. If there is any suspected cancer, sometimes patients ಹೇಳ್ತಾರೆ ಇಲ್ಲ ರೀ ನಿನ್ನೆ ಭಾಳ ಯೂರಿನಲ್ಲಿ ಬ್ಲಡ್ ಆಗ್ತಾ ಇತ್ತು ಇವಾಗ ಏನಿಲ್ಲ. No, he has to be referred without fail because symptoms sometimes occur, sometimes symptoms will not be there. So symptoms ಇದ್ದಾಗ ಅಷ್ಟು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕು ಅಂತಲ್ಲ. ಯಾವಾಗ ಸಿಂಪ್ಟಮ್ಸ್ ಇರುತ್ತೋ ಅವಾಗೇ ಕಾಯಿಲೆ ಇದೆ ಅಂತ ಅನ್ನಕ್ಕಾಗಲ್ಲ. ಯಾವಾಗ ಪೇಷಂಟ್ ಒಂದ್ಸರಿ ಸಿಂಪ್ಟಮ್ ಬಂದ್ರೂ ಸಹ ಅವ್ರನ್ನ ಇಮಿಡಿಯೇಟ್ ಆಗಿ ರೆಫರೆನ್ಸ್ ಕೊಡಬೇಕು. Patient should go and take the treatment or call the urologist and give the treatment. If failed catheterization, take help from the urologist. So final take home message is most of the urological problems, as I told earlier, are due to 3 reasons: obstruction, infection, and cancer. Early diagnosis prevents complication. Please avoid antibiotic misuse. If you continue to give antibiotics like this, in the future, we may not have antibiotics. Antibiotic-induced renal failure is also common. Analgesics-induced renal failures are also increasing. Unfortunately, this analgesics-induced renal failure is very difficult to treat. So timely referral saves kidney and life. Thank you once again for giving me this opportunity. I have written a book called as Kidney Wellness Handbook. All the tips has been given about the kidney problems, how to prevent the kidney problems. The main reason I have written this book is to create awareness about the kidney problems to the public and the practitioners, nursing students, medical students. Everyone can read this and get some knowledge and share to other friends also. So early diagnosis, timely referral, and patient awareness can save both kidney and life. So on this wonderful day, today throughout the world, Physicians Day, ಮತ್ತೆ ಗ್ರೂಪ್ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್ ಡೇನ ಸೆಲೆಬ್ರೇಷನ್ ಮಾಡಲಾಗ್ತಾ ಇದೆ. ಮುಂಚೆ Indian Medical Association Karnataka State Branch extends its heartfelt gratitude for all the family physicians. You are the bedrock of healthcare, providing continuous, compassionate and comprehensive care to families across the communities. ಅಂತ ಹೇಳ್ತಾ, the strength of healthcare begins with the wisdom of a general practitioner ಅಂತ ಹೇಳ್ತಾ, ನನಗೊಂದು ಇವತ್ತು ವೆಬಿನಾರ್ನ ಕಂಡಕ್ಟ್ ಮಾಡೋದಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿರುವಂತಹ IMA ಕರ್ನಾಟಕ ಸ್ಟೇಟ್ ಬ್ರಾಂಚ್ ಮತ್ತು IMA CGP ಎಲ್ಲರಿಗೂ ನನ್ನ ಕೃತಜ್ಞತೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ ನನ್ನ ಈ ಸೆಮಿನಾರ್ನ ನಿಲ್ಲಿಸ್ತಾ ಇದ್ದೀನಿ. ವಂದನೆಗಳು. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
Thank you very much, sir. Dr. Suriraj, sir. Any questions?
Sir, ನನ್ನ ಕಡೆಯಿಂದ ಒಂದು
From the
ಕ್ವಶನ್ ಇದೆ.
audience.
Yes,
Sir,
sir.
the presentation was very good.
Thank you.
I'm a gynecologist. Repeatedly, we see repeated section patients in future pregnancy, second or third pregnancies. ಆ ಬ್ಲಾಡರ್ ಸ್ವಲ್ಪ ಅವ್ರಿಗೆ ಪ್ರಾಬ್ಲಮ್ ಆಗಿರುತ್ತೆ ಅಥವಾ ಅಟ್ಯಾಚ್ಮೆಂಟ್ ಟು ದ ಯೂಟ್ರಸ್ ಆರ್ ಟು ದ ಆಂಟಿ ಅಬ್ಡಾಮಿನಲ್ ವಾಲ್. ಇಲ್ಲಿ ಕಲ್ಚರ್ ಸೆನ್ಸಿಟಿವಿಟಿ ನಾರ್ಮಲ್ ಇರುತ್ತೆ, ಬಟ್ ರಿಪೀಟೆಡ್ಲಿ ದೇ ಕಮ್ ವಿತ್ ಯೂರಿನರಿ ಸಿಂಪ್ಟಮ್ಸ್. ಹೌ ಟು ಗೋ ಅಬೌಟ್ ಸರ್? ಆಸ್ ಯು ಸೆಡ್, ಕಲ್ಚರ್ ಸೆನ್ಸಿಟಿವಿಟಿ ಮಾಡಿದಾಗ ನಾರ್ಮಲ್ ಅಂದರೆ ದೆರ್ ಇಸ್ ನೋ ದ ಕಲೋನಿಯಲ್ ಕೌಂಟ್ ಇಸ್ ನಾರ್ಮಲ್ ನಾಟ್ ಫೌಂಡ್, ಆ ಥರ ಬರುತ್ತೆ. ಅವ್ರಿಗೆ ಹೇಗೆ ಹೋಗಬೇಕು? ನಂಬರ್ 1. Second one is ಸ್ವಲ್ಪ elderly patients, 60-70 years. They have the urethral caruncle, sir. Female patients, many people have seen. How to go about them? These 2 questions from my side, sir.
Very good question, madam, because I also come across a lot of patients. Recently, I came across one patient, postpartum, means after delivery, patient came with urinary retention. Yeah, that what happens, atony of the bladder is very common due to hormonal changes.
Okay.
And in that condition, temporary catheterization, observation, and intermittent to know the sensation whether patient is getting the bladder sensation or not, wait and watch. After 2 to 3 weeks, most of the time, they pass the urine, madam. ಒಂದು ಎರಡನೇದು, ಡೋಂಟ್ ಓವರ್ ಟ್ರೀಟ್. ಈಗ ಮೆಡಿಕೇಶನ್ಸ್ನ ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಡೋದು, ಮತ್ತೆ ಸಿಂಪಲ್ PU catheterization, observe for time 2 to 3 weeks and patient will be all right. Why? What happens no? Sometimes ಈ ಬ್ಲಾಡರ್ ಡಿಸ್ಟೆನ್ಷನ್ ಆಗಿರುತ್ತೆ, ಪೇಷಂಟು ಅದ್ರ ಮೇಲೆ ಜ್ಞಾನ, ಅದ್ರ ಮೇಲೆ ತ್ಯಾಸ ಕೊಟ್ಟಿರಲ್ಲ, ಡಾಕ್ಟರ್ಸ್ ಕೆಲವು ಸರಿ ಅದನ್ನು ಅಬ್ಸರ್ವ್ ಮಾಡಿರಲ್ಲ. ಬ್ಲಾಡರ್ ಸ್ಟ್ರೆಚ್ ಆದಾಗ ಮಸಲ್ ಏನಾಗುತ್ತೆ, ಸ್ಟ್ರೆಚ್ ಆಗ್ಬಿಟ್ಟು ಮತ್ತೆ ಅದು ನಾರ್ಮಲ್ ಪೊಸಿಷನ್ ಬರೋದಕ್ಕೆ ಇಟ್ ವಿಲ್ ಟೇಕ್ ಸಮ್ ಟೈಮ್. ದಿಸ್ ಈಸ್ ವೆರಿ ಕಾಮನ್. And following hysterectomy or any major surgeries like bowel surgery for malignancy, sometimes some of the nerves which supplies the bladder may get disturbed. And most of the time, they regain their strength. We have to wait for the time. 3 weeks to 6 weeks is ideal, madam. Second thing, carankle ಹೇಳಿದ್ರಲ್ಲ.
Yes, sir.
The carankle is causing acute urinary retention, dysuria, and poor urinary stream and recurrent urinary tract infection. Then carankle excision is required. Under local, we can do that. If his patient is asymptomatic, one urinary tract infection, you need not treat them, madam.
In case of previous LSCS, pregnancy pregnancy duration, they come with urinary symptoms, sir. They maybe 3rd month and up to 8th, 9th month, they'll come with the urinary symptoms, but there'll be no symptoms of fever, chills and all, but still they'll be having that incomplete passing of the urine, or there'll be pain on the suture line of the previous LSCS,
Yes.
and there'll be little bit how the alvanta tenderness irutte. So how to go about this, sir? And
Madam, my
yes.
personal feeling is, see, when you do an ultrasound,
Okay.
ultrasound ಅಲ್ಲಿ post wide residue 50 to 60 ml ಕೆಳಗಡೆ ಇತ್ತಂದ್ರೆ ವರಿನೇ ಮಾಡಬೇಡಿ.
Oh, that point. Yes.
Yeah.
Yes, sir.
Just check for post wide residue. If significant post wide residue ಇತ್ತಂತಂದ್ರೆ more than 150 ml, 100 ml ಇತ್ತಂದ್ರೆ we can tell them double widening
Yes.
or triple widening.
Okay.
And
This point yaru helilla, sir.
yes, madam. And most important thing is how much water she is taking. That is also important. Either underhydration or overhydration. That point we should take. And always lifestyle modifications like how much coffee she is taking, how much tea she is taking. Those things are very important. Most of the time we ignore. We think that medications will solve the problem. Because if you stop the medications, if you stop coffee intake or tea intake, our symptoms will vanish, madam.
Beautiful, sir. Just beautiful.
And if patient is having chronic constipation, treat the constipation.
Yes.
That also is known to cause urinary symptoms.
Done, sir. Very good point, sir. Thank you.
Sir, what about cystitis, sir?
Sir, cystitis is not a disease, first and foremost. Second thing ಏನಂತಂದ್ರೆ, for example, ultrasound ಅಲ್ಲಿ cystitis ಅಂತ ಕೊಡ್ತಾರೆ ಅಂತ ತಿಳ್ಕೊಳ್ಳಿ. Ignore it.
No, sir.
It is their finding. As a clinician, I will think about it. Associated symptoms idava ilva. For example, patient is having benign prostatic hyperplasia with a poor urinary stream, sensation of incomplete emptying, cystitis ittappa andre alpha blocker ಕೊಟ್ಟು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದ್ರೆ ಅದು ರಿಲೀವ್ ಆಗುತ್ತೆ. ಜಸ್ಟ್ ಬಿಕಾಸ್ ಸಿಸ್ಟೈಟಿಸ್ ಅಂತ ಕೊಟ್ಟಿದ್ದಾರೆ ಅಂದ ತಕ್ಷಣ ಮೆಡಿಕೇಶನ್ಸ್ ಕೊಡುವಂತಹ ನೆಸೆಸಿಟಿ ಬರಲ್ಲ.
Chronic diabetes ಅಲ್ಲಿ?
Yes, excellent question. Especially diabetes patient ಅಲ್ಲಿ uncontrolled ಇದರ uncontrolled ಇದೆಯಾ? Uncontrolled ಇತ್ತಪ್ಪ ಅಂತಂದ್ರೆ control the diabetes mellitus. That's it. Urine culture and sensitivity, unless patient have symptoms, don't treat. There is a condition called as asymptomatic bacteriuria. In asymptomatic bacteriuria, no indication of any antibiotics. Patient is symptomatic, then only do culture and sensitivity and start the antibiotic. Just because patient came with, sometimes in our routine practice, we are busy. Patient ಒಂದು ಸರಿ ಯೂರಿನರಿ ಟ್ರ್ಯಾಕ್ಟ್ ಇನ್ಫೆಕ್ಷನ್ ಹಿಂದ್ಗಡೆ ಒಂದು ವಾರದಿಂದ ಬಂದಿರ್ತಾರೆ, ಸ್ವಲ್ಪ ರಿಲೀಫ್ ಸಿಕ್ಕಿರುತ್ತೆ, ಮತ್ತೆ ಬರ್ತಾರೆ ಅಂತ ತಿಳ್ಕೊಳ್ಳಿ. ನಮ್ಮ ತಲೆಯಲ್ಲಿ ಏನು ನೋಡುತ್ತೆ, ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಟ್ಟು ಕಳಿಸ್ಬಿಡೋಣ ಸಾಕು ಅಂತ. ಪ್ಲೀಸ್ ಡೋಂಟ್ ಡೂ ದ್ಯಾಟ್. Why she is coming again and again? What is the underlying cause? Is she diabetic? Is she having chronic constipation? Or any stone is there or not? We need to do proper evaluation.
Thank you, sir. Any more questions from the audience?
Good evening to all.
Namaste, sir.
Good evening, sir.
Surya sir, excellent talk.
Thank you,
Really,
sir.
we are proud of you. Congratulations.
Thank you, sir. Thank you.
More than this, I cannot say anything.
Thank
It
you,
is
sir.
very, very useful for the general practitioner, and also
Sir.
really very good information tips you have given to us. Thank you once again. Okay.
Thank you, sir. Thank you, sir.
Okay. Bye.
Sir, basically many mistakes ಮಾಡ್ತಿರ್ತೀವಿ, especially
Yes,
patients with pre or post op catheterization technique ಆದಾಗ, especially THR patients ಅಲ್ಲಿ if there is some urinary tract infection, so ಅವಾಗೆಲ್ಲ ನಾವು ಕೆಲವೊಂದು ಪ್ರಿಕಾಷನ್ ತಗೋತಿರ್ತೀವಿ ಸರ್. ಬಟ್ ಬೇಸಿಕ್ ಅಡ್ಮಿಷನ್ ಆದಾಗ ಕೆಲವೊಂದ್ಸಲ ಏನೇನ್ ಮಿಸ್ಟೇಕ್ ಮಾಡ್ತೀವೋ ಅದೆಲ್ಲ ನಮ್ ಪಾಯಿಂಟ್ ಔಟ್ ಆಗ್ತದೆ ಸರ್. ಅದು
ಸರ್ ಭಾಳ ಒಳ್ಳೆ ಪಾಯಿಂಟ್ ಹೇಳಿದ್ರಿ ಸರ್. ನಾವೇನು ಅನ್ಕೋತೀವಿ ಸರ್, ನಮ್ಮ ಯಾವುದು ಸರ್ಜರಿ ಇದೆ ಅದ್ರ ಮೇಲೆ ಫೋಕಸ್ ಮಾಡಿರ್ತೀವಿ ಸರ್. ಅಸೋಸಿಯೇಟೆಡ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಬಗ್ಗೆ ನಾವು ಸ್ವಲ್ಪ ಫೋಕಸ್ ಮಾಡಿರಲ್ಲ. ಎಕ್ಸಾಂಪಲ್, ಯೂರಾಲಜಿಯಲ್ಲಿ ಪೇಷಂಟ್ ಲಿಥಾಟಮಿ ಪೊಸಿಷನ್ ಇಂದ ಎಷ್ಟೋ ತೊಂದರೆಗಳಾಗ್ಬಿಟ್ಟಿರ್ತವೆ ಕೆಲವು ಸರಿ. ಆಮೇಲೆ ಪೇಷಂಟ್ನ ಪ್ರೋನ್ ಮಲಗಿಸ್ಬೇಕಾದ್ರೆ ಕೆಲವು ಸರಿ ಶೋಲ್ಡರ್ ಡಿಸ್ಲೊಕೇಶನ್ ಆಗಿರುತ್ತೆ, ಆಮೇಲೆ ನೆಕ್ ಇಂಜುರೀಸ್ ಆಗಿರ್ತವೆ. ಅದ್ರ ಬಗ್ಗೆ ನಾವು ಈಕ್ವಲಿ ಇಂಪಾರ್ಟೆನ್ಸ್ ಕೊಡಲೇಬೇಕು ಸರ್. ಅದೇ ಥರನೇ ತಾವು ಹೇಳಿದಂಗೆ ಪರ್ ಯೂರಿಥ್ರಲ್ catheterization is very important, sir. Proper lubrication, make sure once the catheter is there, 1 or 2 drops of urine comes, then only inflate the bulb, sir. ಕೆಲವು ಸರಿ ಯೂರಿಥ್ರದಲ್ಲಿ ಬಲ್ಬ್ ಇನ್ಫ್ಲೇಟ್ ಮಾಡಿ ಎಷ್ಟೋ ಸರಿ ಯೂರಿಥ್ರಲ್ ಇಂಜುರಿ ಆಗಿದಾವೆ.
ಸರ್ ವೆರಿ ಕಾಮನ್. ಅದಕ್ಕೆ ನಾವು ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಆಗಿ OT-ಯಲ್ಲೇ ಪ್ರೀ ಆಪರೇಟಿವ್ ಅಷ್ಟೇ ಅಲ್ಲೇ ಹಾಕೋ ಸರ್. ಬಟ್ ಈಗ ಎಸ್ಪೆಷಲಿ THR ಇಲ್ಲ ಕೇಸಸ್ ಅಲ್ಲಿ ಆತರ ಆಗಕ್ಕೆ ಬಿಡಲ್ಲ.
ಕರೆಕ್ಟ್
ಸರ್, one question ಇತ್ತು regarding patients like hydronephrosis with small stones less than 4 millimeter. Usually how to handle, sir? They will be having pain, whether we need to give IV antibiotic and wait, or how it is? Because most of the patients come with hydronephrosis and they will be having some small stone. If there is more than 4 millimeter, usually something will be done, or how it is, sir?
ಸೊ ವೆರಿ ಗುಡ್ ಕ್ವಶನ್ ಸರ್. ಯಾಕಂದ್ರೆ ಸೈಜ್ ಇಸ್ ನಾಟ್ ದ ಕ್ರೈಟೀರಿಯಾ. ವಾಟ್ ಈಸ್ ದ ಇಂಪ್ಯಾಕ್ಟ್ ಆಫ್ ದ ಸ್ಟೋನ್ ಆನ್ ದ ಕಿಡ್ನಿ, ದಟ್ ಇಸ್ ಈಕ್ವಲಿ ಇಂಪಾರ್ಟೆಂಟ್ ಸರ್. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ 4 mm ಗೆ ಕೆಲವರಿಗೆ ಭಾಳ ದೊಡ್ಡದು, ಕೆಲವರು 1 centimeter ಸ್ಟೋನ್ ಯೂಸ್ ಪಾಸ್ ಮಾಡ್ತಾರೆ. ಈಗ 4 mm ಇದ್ದು ಮಾಡರೇಟ್ ಟು ಸಿವಿಯರ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್ ಇದ್ರೆ ಇಂಟರ್ವೆನ್ಷನ್ ಇಸ್ ಮಸ್ಟ್. ವಿ ಕಾಂಟ್ ಜಸ್ಟ್ ಟೆಲ್ ದಟ್ 4 millimeter ಇದೆ, ವಿ ವಿಲ್ ಗಿವ್ IV fluids ಅಂಡ್ ಅನಾಲಿಸಿಸ್ ಕೊಡ್ತೀವಿ ಅಂತ ಹೇಳಿ ನಾವು ಕಿಡ್ನಿನ ರಿಸ್ಕ್ ಕೊಡೋಕ್ಕಾಗಲ್ಲ. ವಿ ಹ್ಯಾವ್ ಟು ಡೂ ಇಂಟರ್ವೆನ್ಷನ್. ಯಾಕಂದ್ರೆ
ಸರ್ ಅದೇ ನೋಡೋದು, ಮೋಸ್ಟ್ ಆಫ್ ದ ಪೇಷಂಟ್ ಬರ್ತಾರೆ, ದೇ ವಿಲ್ ಬಿ ಹ್ಯಾವಿಂಗ್ hydronephrosis, and once ಅವ್ರ ಪೇನ್ ರಿಲೀಫ್ ಆದ್ರೆ ಮತ್ತೆ ವಾಪಸ್ ಬರಲ್ಲ. ದಟ್ ವಿಲ್ ಕಾಸ್ ಲಾಟ್ ಆಫ್ ತೊಂದರೆ, ಡಿಲೇಡ್ ಮತ್ತೆ ಬರೋಕೆ ಲೇಟ್ ಆಗಿ ಮತ್ತೇನು ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಗತ್ತ ಅಂತ ಆಲ್ವೇಸ್ ಐ ಫೀಲ್.
Exactly, sir. Sometimes symptomatic treatment is dangerous. Why? Because patient is having symptoms, they go to the doctor and take the treatment. If symptoms vanish ಆಗ್ಬಿಡ್ತಂದ್ರೆ ಅದ್ರ ಬಗ್ಗೆ ತಲೆನೇ ಕೆಡಿಸ್ಕೊಳ್ಳಲ್ಲ.
ಅದೇ ಸರ್.
ಅವಾಗ ಏನಾಗುತ್ತೆ ಸರ್, ಆ ಸ್ಟೋನ್ ಇಂದ ಕಿಡ್ನಿ ಡ್ಯಾಮೇಜ್ ಆಗಿ ಕಿಡ್ನಿ ನಾನ್ ಫಂಕ್ಷನಿಂಗ್ ಆಗ್ಬಿಡುತ್ತೆ. ಅಂಡ್ ಅಗೇನ್ patient think that if the pain is not there, his problem is solved. One thing important is understand, if kidney is not functioning, they will not have pain.
Most of the patient we feel this, sir, but sometimes the patient ಹೇಳ್ತಾರೆ ಕನ್ಸರ್ವೇಟಿವ್ ಮಾಡಿ ಪೇನ್ ಕಡಿಮೆ ಆಗುತ್ತೆ ಅಂತ. We always I was feeling this. Thank you, sir. This was a very good insight for me.
Yes, sir. Thank you, sir.
Hello.
Sir.
Asymptomatic BPH.
Yeah.
And ultrasound more than 150 ml post-void. Trabeculations are there.
Okay.
But patient is passing urine without any difficulty and good flow.
Okay. Sir, good flow ಅಂದ್ರೆ ಎಷ್ಟು ml ಇದೆ per second? ಅದು ಇಂಪಾರ್ಟೆಂಟ್.
Eurometer is not done.
ಓಕೆ.
Euroflow meter is not done.
ಏನಾಗುತ್ತೆ ಸರ್, ಈಗ ಸಿಂಪ್ಟಮ್ಸ್ ಅನ್ನೋದು ಪೇಷಂಟ್ ಮೇಲೆ ಡಿಪೆಂಡೆಂಟ್ ಆಗಿರುತ್ತೆ ಸರ್. ಕೆಲವರಿಗೆ ಹೈಯೆಸ್ಟ್ ಸಿಂಪ್ಟಮ್ಸ್ ಇರ್ತವೆ, ಅದನ್ನ ಅವ್ರು ಹೇಳ್ಕೊಳಲ್ಲ. ದೇ ಥಿಂಕ್ ದಟ್ ಇಟ್ಸ್ ಓಕೆ ನಾರ್ಮಲ್. ಕೆಲವರಿಗೆ ಮೈಲ್ಡ್ ಸಿಂಪ್ಟಮ್ಸ್ ಇರುತ್ತೆ, ಅದನ್ನ ಎಕ್ಸಾಗರೇಟ್ ಮಾಡ್ತಾರೆ. ಸೊ ಇಯರ್ ನಿಮ್ಮ ಕಂಡೀಷನ್ ಅಲ್ಲಿ ಪೋಸ್ಟ್ ವರ್ಡ್ ಸಿಗ್ನಿಫಿಕೆಂಟ್ ಇದೆ, ಟ್ರಬ್ಯಾಕ್ಯುಲೇಷನ್ ಇದೆ ಅಂದ್ರೆ ದೇರ್ ಇಸ್ ಅಬ್ಸ್ಟ್ರಕ್ಟಿವ್ ಸಿಂಪ್ಟಮ್ಸ್ ಇದೆ ಅಂತ ಅರ್ಥ. ಸೊ ಇಟ್ ಮೀನ್ಸ್ ದಟ್ ಹಿ ರಿಕ್ವೈರ್ಸ್ ಮೆಡಿಕಲ್ ಲೈನ್ ಆಫ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫಾರ್ ಫ್ಯೂ ಡೇಸ್. ಹೌ ಈ ರೆಸ್ಪಾನ್ಸ್ ಆಫ್ಟರ್ 3 to 4 weeks ಆದ್ಮೇಲೆ ಮತ್ತೆ ಇನ್ನೊಂದ್ಸರಿ ಅಲ್ಟ್ರಾಸೌಂಡ್ ಮಾಡಿ ನೋಡೋದು ಬೆಟರ್ ಸರ್. ಅಂಡ್ ಇಫ್ ಇಟ್ ಪರ್ಸಿಸ್ಟ್, ವಿ ನೀಡ್ ಟು ರೂಲ್ ಔಟ್ ವೆದರ್ ಪೇಷಂಟ್ ಇಸ್ ಡಯಾಬಿಟಿಕ್ ಆರ್ ನಾಟ್. ಪೇಷಂಟ್ ಡಯಾಬಿಟಿಕ್ ಇತ್ತಪ್ಪ ಅಂದ್ರೆ ಮೇ ಬಿ ಡ್ಯೂ ಟು ನ್ಯೂರೋಜೆನಿಕ್. ಅಂಡ್ ಅಗೇನ್ ಪ್ರಾಸ್ಟೇಟ್ ಸೈಜ್ ಎಷ್ಟಿದೆ ಸರ್?
I don't remember that one,
Okay.
but it's BP is there.
Okay.
Probably grade 2 or 3.
Okay, sir. So definitely we have, sir, actually lower urinary tract symptoms may be due to diabetes, hypertension, and BPH, and those things. We have to find the underlying cause, sir. In some reasons, we may require, we need urodynamic study also sometimes. If prostate is small, patient is having lower urinary tract symptoms, we need to rule out what is the function of the bladder. Whether it's producing adequate pressure to push the urine out or not, that is also equally important. We most of the time what we think, okay, patient is having poor stream of the urine, maybe due to BPH. It's not always true. It may be due to inadequate pressure by the urinary bladder. So definitely he requires proper intervention, sir. Medications ಬೇಕಾಗಬಹುದು, observation and follow up ಬೇಕಾಗುತ್ತೆ sir ನಿಮ್ಮ patient ಗೆ.
Okay, thank you.
Sir, finally, in the rural practice, in PHCs, a patient come with renal colic, we will be 190% we will be sure that it is renal colic. What is the first line of treatment can be given?
So first assessment is very important. Example, what is the size of the stone, site of the stone, what is the impact of the stone on the kidney, associated comorbidities idava ilva. So kindly, that's what I was telling, don't start analgesics simply, don't start antibiotics without any proper evidence. Analgesics induced nephropathies are very common, and most of the time they are irreversible. So it depends upon the stone. For example, 4 mm ittu, mid ureter and lower ureteric stone ittu, ಅವ್ರಿಗೆ ಡಯಾಬಿಟಿಸ್ ಇಲ್ಲ ಏನಿಲ್ಲ ಅಂದ್ರೆ ಡೆಫಿನೆಟ್ಲಿ ಗುಡ್ ಅನಾಲ್ಜೆಸಿಕ್ಸ್. ಅಗೇನ್ ಸೆಕೆಂಡ್ ಕ್ವಶನ್ ಈಸ್ ಅನಾಲ್ಜೆಸಿಕ್ಸ್ versus flush therapy versus observation. So simple analgesics are more than sufficient. No role of flush therapy. Of course, the patient is having hypotension, ಬೇರೆ ಏನಾದರೂ associated symptom ಇತ್ತಂದ್ರೆ ಐ ಫ್ಲೂಯಿಡ್ ಕೊಡಬೇಕು. ಸ್ಟೋನ್ ಪುಷ್ ಮಾಡೋದಕ್ಕೆ, ಸ್ಟೋನ್ ತೆಗೆಯೋದಕ್ಕೆ ಫ್ಲಶ್ ಥೆರಪಿ ಇಲ್ಲ. No role of flush therapy.
Okay, sir. So any other questions from the audience? So probably no, sir.
Okay.
Can you close, sir?
Yes, Mahesh.
Okay, sir. Thank you everyone for attending this webinar on common neurological problems by our IMA KSB Secretary, Honorary Secretary Dr. Suri Raju sir, and a wonderful presentation. And I once again thank all the participants who attended and made this a grand success. Thank you very much, sir. Good night.
Thank you for giving opportunity. Thank you all.
Thank you, sir.
ಯಾರಿಗೆ ಕ್ಲೋಸ್ ಮಾಡಿ